Good morning, everyone. Great, thank you so much, session chair and my newfound friend, Dr. Kirmax. And I want to start by thanking the organizers of Interest Conference 2022 for this opportunity, also to talk about orphans and vulnerable children, a subject that I'm most passionate about. So this morning, my presentation will give you social work and community approaches that, alongside the clinical interventions, have contributed significantly to improving pediatric HIV outcomes within orphans and vulnerable children programs. So the presentation will specifically talk about the state-of-the-art interventions in improving pediatric HIV outcomes in orphans and vulnerable children programs. The presentation outline will include improvements in pediatric and adolescent HIV outcomes. I'll talk a bit about the continued gaps and challenges, just for all of us to appreciate the need to do something out of the norm. Then I'll talk about the OVC program's contributions to pediatric care and treatment outcomes. I'll make some conclusions and recommendations. So what are some of the gains, the improvements that we collectively in the HIV fraternity have made in the last 1 decade? Clearly, treatment coverage among pregnant and breastfeeding women living with HIV has increased from 45% to 85% globally. That's a big improvement. New HIV infections among children decreased by 53% globally and by 64% in East and Southern Africa. We did great there. Globally, AIDS-related death among children 0 to 9 years decreased by 60% between 2010 and 2020. Additional improvements include new HIV infections among adolescents ages 10 to 19 decreased significantly by 1/3 globally and by 41% in East and Southern Africa. New HIV infections among adolescent girls and young women ages 10 to 24 declined by 24% from 2015 to 2020. AIDS-related death among adolescents aged 10 to 19 decreased by 37%. So we have gains to celebrate. It's not all gloomy. However, we need to take stock about the persistent gaps in pediatric HIV, globally and specifically in Africa. As of 2020, 1.7 million below the age of 15 years were living with HIV. 60% of those were aged between 5 to 14 years. In 2020 alone, there were 150,000 new HIV infections among children. 84% of these new infections occurred in sub-Saharan Africa, and almost all the new infections occurred during pregnancy, birth, and the breastfeeding period. More than 2/5 of children living with HIV remained undiagnosed due to gaps in early infant diagnosis. So there are specific gaps in pediatric HIV globally that continue to bother us. The antiretroviral therapy coverage among children aged under 15 years was only 54% globally. That is 20% behind that of adults living with HIV. Although there was a decline, this was a decline compared to 2019, and it left 800,000 children living with HIV without treatment. Only 40% of children living with HIV were virally suppressed, compared to 67% of adults globally. That's very concerning. Children under 15 years accounted for only 5% of people living with HIV, but comprised 15% of people who died of AIDS-related death. So specifically in sub-Saharan Africa, as of 2020, the 21 focus countries of Start-Free, Stay-Free, AIDS-Free framework in sub-Saharan Africa accounted for 83% of the global number of pregnant women living with HIV and 80% of the number of children living with HIV, and 78% of the number of young women ages 15 to 24 newly infected with HIV. So there is a lot of work to do in sub-Saharan Africa. The gaps in mother-to-child transmission, and the UNICEF presentation, I think, dwelt a lot on it. I will not dwell a lot on it. There are gaps in pediatric HIV testing and treatment cascade. As you can see from this presentation, you can make a comparison between global, East and Southern Africa, West and Central Africa in relation to the testing and treatment cascade for children 0 to 14. Let me point out, I hope this works. The pointer doesn't seem to work for me. But I wanted to highlight, if someone mentioned the gap, the gap that is in Western and Central Africa. For example, the first 95, if you look at the global performance status, you'll notice that while the global status is 59%, in Western and Central Africa, it is only 35%. Same with the second 95, while the global performance is at 54%, Western Central Africa is at 35%. And for the third 95, while the global performance is at 40%, Western Central Africa is only at 24%. Eastern and Central Africa is not significantly performing better. So gaps among adolescent girls. As of 2020, there were 1.7 million adolescents ages 10 to 19 living with HIV. Sometimes these statistics simply pass as statistics, but you can imagine 1.7 million adolescents if they were converged in this place, how big that would look. So these numbers have faces behind them, and they're so concerning. So adolescents living with HIV account for 5% of all people living with HIV, and about 1.5 million, 88% of those are in sub-Saharan Africa. In 2020 alone, 410 adolescents ages 10 to 24 were newly infected with HIV globally. 150,000 were adolescents 10 to 19, who account for about 11% of new adult HIV infections. Adolescent girls and young women account for 4/5 of all new infections among adolescents. And in sub-Saharan Africa, 15 to 24-year-olds account for 25% of all new HIV infections. So if there is any subpopulations that need special attention, it's children and adolescents within the epidemic control framework. So only 54% of adolescents ages 10 to 19 received antiretroviral treatment globally. So we have 46% of adolescents living with HIV that are not on treatment, and those need to be found. In West and Central Africa, treatment coverage among adolescents living with HIV ages 10 to 19 was only 43%. That should concern us. 32,000 adolescents ages 10 to 19 died of AIDS-related causes in 2020 globally. So what are the key actual challenges that explain these statistics. So the challenges relate with continued HIV infection as a result of insufficient treatment coverage among pregnant and lactating women to prevent child infections through vertical transmission. As you know, many women don't deliver in healthcare settings, or when they do, it's late, and as a result, they are missed by HIV treatment services. They never get diagnosed and linked to treatment. Many HIV-positive women drop out of treatment during pregnancy and breastfeeding period due to lack of social support for treatment continuity. We had a story yesterday, I think, of the woman who took 12 years to get to treatment, and somehow they were going to the health center, to a hospital. So there is heightened risk of HIV acquisition as another big challenge among adolescents and young women. In 2020, almost 6 times as many adolescent girls were newly infected with HIV compared to their counterparts, the adolescent boys in sub-Saharan Africa. 6 times more at risk for adolescent girls. So contributing factors that explain this include harmful gender norms, sexual violence and coercion, age-disparate sex, lack of access to sexual reproductive health services, low condom use, and early sexual debut. In regards to challenges related to HIV diagnosis and linkage to treatment for infants and children, there is low rate of early infant diagnosis and immediate linkage to HIV treatment amongst HIV-exposed infants. Finding HIV-positive children missed at birth or during breastfeeding. Nearly 2/3 of children living with HIV are not on treatment are ages 5 to 14, and these cannot be found through postnatal care visits. So there have to be some other means through which we can find these children. For adolescents, there is low HIV testing coverage. Adolescents fear stigma. I think there's been a lot of discussion. I was so happy that we discussed stigma and discrimination in the health facilities. And prohibitive laws still exist in many of the countries in sub-Saharan Africa. For example, those laws that require consent of guardians or parents for adolescents below, or children and adolescents below age 18. So treatment continuity and adherence challenges. Many infants and young children are still in suboptimal pediatric HIV treatment regimens. Infants and children depend on their caregivers to administer their medications. Many children and adolescents have not been disclosed to and unaware of their HIV status and why they need to take daily medications. Many children take, I don't know why I'm taking these medications, because their parents have not disclosed. Children and adolescents in vulnerable households often lack money for transportation to the health facility to pick up their medications. I may not have food to take their medications. Those factors do affect demand and access for services. So I wanted to talk a little bit about how the Orphans and Vulnerable Children programs are helping improve child and adolescent HIV outcomes for all of us here who are policymakers, implementers, to go and ponder along to consider for integration and prioritization in the HIV response. So these orphans and vulnerable children are predominantly implemented in PEPFAR priority sites that have highest HIV burden. They utilize 2 implementation models. OVC programs are implementing 2 main models. One is comprehensive case management for OVC subpopulations, and the second model is primary prevention of sexual violence and HIV for young adolescent girls and boys. And the comprehensive case management interventions lead to measurable outcomes. And these outcomes are categorized under 4 domains. And each one of those domains, they are indicators that measure outcomes that these programs achieve. And they are healthy, the domains are healthy, safe, stable, and schooled. And there are specific indicators, for example, under health, very specific HIV indicators. For example, all the beneficiaries in the OVC programs must have known their HIV status. That means they must have either tested or confirmed that they do not require testing. They have to be virally suppressed if they are HIV positive, both children and caregivers, and they have to be knowledgeable about HIV prevention, and the children and adults must not be malnourished. Under the comprehensive component, the OVC programs target specified subpopulations that are with an elevated HIV risk factors. And these include children and adolescents living with HIV. They include children of adults living with HIV, especially those at risk of treatment interruption, orphans, and HIV-exposed infants of mothers at risk of interrupting treatment, children of female sex workers, and children who are survivors of sexual violence. And sometimes in conflict situations, this includes children who are at risk of sexual violence. Their OVC programs are implemented in close coordination with clinical partners and health facilities, as you can imagine, to facilitate bidirectional referrals between health facilities and communities in order to increase access to services. They offer intensive services and support to eligible children through comprehensive case management. They support pediatric HIV, the entire cascade of HIV. This slide highlights a set of interventions that the OVC programs implement in the different, the cascade, across the 395s. For example, under the first 95, OVC programs refer biological children and siblings for index testing. The OVC programs have been so instrumental in facilitating index testing at the community level. For the second 95, for example, the OVC programs conduct routine home visits and follow up on clients facing an interruption in treatment. I think we had a presentation yesterday that talked about the role of community organizations in access to services. So the OVC programs have a robust network of social support cadres, social service cadres at the community level. For example, OVC programs have caseworkers, and each caseworker has 10 households that they monitor. And so you can imagine 10 households that caseworkers are able to monitor very regularly on treatment adherence and all the package of services. And then there is a cadre of social workers that supervise the caseworkers, and then we have HIV linkage coordinators in the health facilities that facilitate bidirectional referral. So we're very close to the families. The OVC programs are very close to the families. And for the third 95, we provide a range of services. I wanted to highlight the delivery of household economic strengthening services that are so instrumental in enabling families to access money to be able to afford medical, food, and education support for their children. So as I mentioned, households in the comprehensive component must meet HIV-related benchmarks before they exit the program. We have to demonstrate, for example, that the HIV-positive beneficiaries, either children or adults, have sustained viral load suppression for 12 months. And then the OVC program can then move on to another, to other beneficiaries who need assistance. So the OVC programs helped prevent risk of sexual violence, which is a very big driver for HIV infection among adolescents, ages 9 to 14 and 10 to 17 through evidence-based interventions. So I wanted to highlight I wanted to quickly highlight examples from program implementation, and this example is from two programs in Mozambique and South Africa, the FHI 360 OVC programs supporting HIV testing and treatment Cascade for children aged 0 to 17. As you can see on the children living with HIV on ART, 99.9% actually, of all the beneficiaries in the OVC program that are HIV positive are on treatment. And 95% of those on treatment received viral load testing in the past 12 months. Viral load suppression is at 88%, not optimal. There's still work to do, but at least much better than the overall picture that we saw in East and Southern Africa. This example is from from PEPFAR program implementation. It's from Malawi. It also demonstrates that the role of the OVC programs, and 99% of all eligible OVC were transitioned to PDTG successfully as a result of a set of comprehensive interventions. So I wanted to conclude by saying that pediatric HIV/AIDS control remains behind adult epidemic control, and we have to do something, all of us in this room. While there are still significant gaps and challenges, there are important opportunities that need to be taken advantage of. And I wanted to highlight this third point, that HIV services are at their most effective with an integrated health and OVC social services workforce model operating with intentional collaboration and coordination between the health and social services. And the OVC programs, as we know, address recognized and unfulfilled need of the socio-economic services that constrain access to services. Some recommendations: scaling up of OVC programming is one recommendation. OVC programs can actively facilitate testing, linkage to treatment, and reducing risk of violence. And strengthening integration, again, I will emphasize that, working with an approach. We all aim at the epidemic control, so we can work together with a common shared outcomes and defining an integrated approach, collaborating together and defining roles of each other, supporting each other to achieve one common goal. And we need to scale up models for strengthening the social service workforce because they are instrumental in improving HIV outcomes. So these are the references for some of the slides in my presentation, and thank you very much. I want to acknowledge PEPFAR USAID, from which the slides, some of the slides were derived, and of course my organization FHI 360 and my colleagues with whom we work together to put up these slides. Thank you so much.